Good morning. Welcome, everyone, to day 3. So we're going to start off today by talking about developing a collaborative relationship with infectious disease specialists, a sales and clinical perspective. And I'm Ansley Lee, and I have no conflicts of interest to disclose.
And I'm Barner Richards, and I do have a consulting role with Eton Medical. And I'm not going to take any guff in any of you that I have other conflicts, so that's what I've got.
So today we're just going to keep this casual and just share our experiences with working with the infectious disease partners that we work with in our area. But we're going to talk about how to become that partner. Then we're going to talk about strategies for achieving those shared outcomes with your infectious disease specialists for their patient population, and then how to achieve desirable healthcare and payer outcomes. So when I was preparing for this conversation, I met with one of our key infectious disease specialists because I really wanted to get a true understanding of the value that she sees in our partnership, but also the role that they play within their healthcare system. And one common theme throughout our entire conversation was, she's like, we're not the big revenue generators. We're not the ones bringing in those big bucks for the hospital system. But what we help with and what we impact is healthcare cost savings. And how they do that is through infection control. We all know the best way to reduce the risk of a patient acquiring another infection is to get them home. And so as a post-acute care partner, that's where we come into play, and that is opportunity for us. So we are going to be working with the infectious disease physicians. They have a high volume of patient population that needs long-term IV antibiotics, and that's where we can come in and help them to get those patients home. Also, they're going to be working with a complex caseload, and so we can come in and collaborate with them, help them know what can be done safely in the home and how they can be successful. And then, of course, once they get home, that is really when all our services come into play. So we're going to dive into this deeper later on in the presentation, but we want to prevent those hospital readmissions and avoid ED visits. So just for a little bit of context for our discussion today, I want to briefly tell you about Intramed Plus. We are an independently owned infusion pharmacy in South Carolina with over 3 decades of experience. It's very beneficial that we're independently owned because that allows us to be flexible, not only with the customizing the treatment plan options for our patients, but also customizing the level of service that we provide to our partners in the community and working with those infectious disease physicians. We are mission-driven culture, and it's because of our team and the experience and their passion for taking care of the patients that has allowed us to develop those strong relationships and have a longevity of 30 years plus in our market. So we do have 3 service lines. Bread and butter is going to be your standard home infusion pharmacy. And so we have a comprehensive therapy mix, but our highest volume is going to be IV antibiotics. And so that does account for about 50% of our annual revenue. Then our other 2 service lines, we have ambulatory infusion centers and ambulatory infusion suites, and then specialty home infusion nursing. These 2 service lines really allow us to provide an extension of services for our IV antibiotic patients and our ID physicians. So for our ambulatory infusion centers, I'm sure everyone has experienced the challenge with securing home health for some of these patients. So we'll have patients that the only barrier for them not being able to discharge home is they have no accepting home health agency. So we're able to bring those patients in to our infusion center weekly for those dressing changes and lab draws to go ahead and get them home and out of the hospital. Also, we are able to if a patient needs a first dose, so they're already on service, they've discharged home, the ID physician needs to change the drug agent, then we're able to bring them into our facility for that first dose in a controlled setting. Also, if they're starting a new patient in the outpatient setting, we're able to take that on and bring them over to us, get that first dose and training done while the patient is there. Also, the 1-dose IV antibiotics, a lot of challenges. One challenge that we see a lot is the patients that have a history of drug abuse, and so ID is not comfortable sending them home with a PICC line and on long-term IV antibiotics. So they are able to discharge the patient can come to us, we can administer that 1-dose IV antibiotic, and then the patient's set. That really comes into play too if those drugs are not on formulary at the hospital. that the physician is working with. And then another option where this comes into play is if a patient gets home and their line becomes occluded, then we can bring them in and administer cath flow. And as I was talking to our infectious disease partner, she was just so thankful that that was a service that we were able to provide now, because if not, that patient had to go to her office and she was having to administer that. And not only was it using their resources, but that was a service that they were unable to bill for. So now that we are able to take that on, we can absorb those costs for them. And then we do have specialty home infusion nursing. It is limited, it's very payer dependent, so we're only going to be able to work with the commercial plans, and it's also a carve out, so we're only able to provide that skilled nursing for the patient related to their infusion services. But this helps us with our IV antibiotic patient population, because if you have a patient with transportation issues and they're not able to make it to the infusion center on a weekly basis, our nurse can go into the home and provide those services. And then also, you just have some patients that aren't able to ambulate and get to the infusion center weekly, so we can still provide those services, and ultimately that patient is getting home and that decreasing that length of stay.
So then let's take a look at the group that we're really trying to focus on, and that would be the infectious disease physicians. And as all of you have been involved in stuff like getting access to them can sometimes be limited. So you really have to look at an approach of who also is involved in that patient's case. And you're trying to do an influence through multiple different groups. And that's actually going to be, and we're going to go into a little bit more, some of the case managers, discharge planners, the other part of the medical team that really has the responsibility of that patients while they're in the hospital. They're the ones who's actually is on admission and also on discharge, where the infectious disease are the consultants. And so the infectious disease people come in a little bit later, they give their recommendations, but they're not fully responsible in a lot of ways during that admission side. It's really more on discharge. And then we'll talk a little bit more about the hospitalist role. But your clinical liaison representatives are very critical, because they got to touch base with everybody. And what you're trying to do is always are trying to prove that you're dependable, accurate, and you're going to be responsive to that patient's needs and what you're really having to have involved in that. One of the big things that's really helped us is, do you have access to the electronic health care record? In our area, it's Epic. And we've always were fighting for that in terms of trying to get access. And over time, when it first came out with PHI and all the HIPAA stuff, nobody could get access until you signed up for your firstborn, and you'd have liability for that type of a thing. But now it's gotten more freer, because the flexibility, you save time. And that's a really important side of that. And then also, you're also looking for home health, because a lot of times, it still happens, the home confusion phenomena still exists. They think home health does IV antibiotics. Well, no, it's the home infusion pharmacy. And so there's some networking side there that you want to be that group, that your home health agency that they provide are going to say, we want to use Intermed Plus. So that's our part with that. You want to do it? So, what type of infectious disease physicians do we work with? We have the gamut. We're in the state of South Carolina, and they range from academic centers. So you have your fellows, you have your attendings, you have residents you're dealing with in terms of that. Very involved in that side. You also have hospitals that they own the practice side for infectious disease physicians. And so they have a different mindset of what they have to do accordingly. Hospitals play a role, especially in our rural hospitals. They don't have the infectious disease caliber type of physician. They may have an internal medicine, or they have somebody who likes antibiotics, and they become designated, but that's becoming less and less. Those fine practitioners are retiring, and you're getting more into these hospitalist type of things. And then you have the independent groups that deal with it. They don't have a problem, except when they get complicated infections. And then you have the areas of the rural hospitals, they don't have an ID physician. And how do they work around that? And now some of the more technologies based, they partner or contract with other hospitals, and they'll do telehealth visits and things like that where you're involved in that. And you have a role in this aspect, because you actually might be the primary one that's doing the communication side of connecting all the dots together. So what do they desire? You always got to look at it from that standpoint. What does an ID doc want to do? I really put the last one down there. They really want payment for really on the top, because they're a lot like us in a lot of ways. We don't get reimbursed enough for what we actually do. But what they're really looking for is some group, some entity to feel responsible and own that patient's care. And that's really what you're looking at. Coordination of the therapy that's going home. You're looking at that patient will be monitored for any adverse drug reactions, compliance, that's what you're looking for, and that you will keep them updated with what the information is. And a lot of times with our physicians, it's if you don't hear from us of an alert or something like that, the patient's doing well. And that's really from a teaming standpoint, we'll talk about it. The coordination of labs. In the old days when we didn't have Epic or those type of things, we would do lab monitoring trends, and we'd fax one-page memo over to them, and it would give them the trend and recommendations if we had that. Ease of use, they want to see consistency of communication. They would love for us to have access to the electronic healthcare record and actually put in information, but that's not there yet for what we deal with and how we do that. So our communication does still come across as a fax or some communication, could be some communication in the chat session that we might have in Epic. The other side that kind of want somebody to handle the venous access management. Quite commonly, what we've always felt with sometimes that happens is the patient's off therapy, they say DC the therapy, but they forget to write the order to discontinue the PICC line or the midline. And so we're always looking at that, and we then coordinate that. So those are some of the things that they're really desiring. They really want a partner in that part of it, and how do you get there is what you're really looking at.
Okay, so I'm going to talk from a sales perspective when you receive that referral from the inpatient side. So I am very, very passionate, and I could talk about this all day long, about the level of customer service that you provide to your hospital team. So at this point in the referral, you're going to be working with your case manager, discharge planner, the hospitalist attending physician, and ID is just going to be consulting at this point. And I'm very passionate about making it an effortless referral process for our referral sources. And one way that we are able to accomplish this is through having Epic access. And that is so invaluable. It allows us to use it how it's intended. So we get the referral, we're able to go in, view the medical record, print any pertinent information that we need, but it allows us to also be proactive. So we're not just sitting around waiting for the case manager to notify us that the patient, the final recs are available and he's ready for discharge. It allows us to be proactive. So we can go in, we can follow along. One of my favorite scenarios is when we already know ID recs are available, line has been placed, we've already coordinated training, and we're calling the case manager back to provide an update. And she had not been aware of any of that yet, and so then she looks like a hero because she can go to the hospitalist attending physician and say, this patient's ready for discharge, it's all taken care of. So really making that effortless. Now, how we do that is all relationship based for us at Intramed Plus, but we have several team members that work together simultaneously to make sure that the needs are being met. So some of the key players, we have your account executive. This is going to be your sales rep. They're going to be the ones that have the relationship with your C-suite executives at the hospital. They're working with your leadership team and the case management department. They have the relationships with the case managers themselves. But they're also working in the outpatient clinic with your infectious disease physicians and their support team and nurses. They're the ones that are really digging deep to identify what their expectations are, what their needs are, what needs are not being met, and how can we better service their patients. And it could be that that account executive is just taking that market intel and communicating it to her team internally, or it could be in some situations where your account executive is the one that has the established relationships with your discharge planners, so then they become the liaison. And so they are playing a dual role. So they're doing the sales piece, but they're also doing a coordination piece and working with those case managers and working with their clinical team internally to get those patients home. Then we have our clinical nurse liaisons. And this position varies too, based on the market and the account. It could be that the clinical nurse liaison is going to be the point of contacts, doing the sales piece, but also the patient education piece. It could be that we have a designated coordinator that is talking with the case managers and arranging the training, and then our nurse liaison is the one that's going on site to do the patient education and working with the medical team. So this is where we are really a true resource. This is where we can get in and we can start talking with the patient and see, are they capable? Are they going to be able to self-administer? Are they going to require a caregiver? Is there a caregiver available? Are there some limitations on their availability? All of those things are coming into play so we can determine what the ID doctor is going to order. Is that something that can be successfully done in the home? We had one case where a resident, it was a pediatric patient, and a resident was ordering multiple therapies that were having to be administered several times a day. So our nurse went in and noticed this, and what she did is she went to that resident and laid out exactly what would have to be done for this to be successful in the home. And he automatically responded, well, I'm setting them up for failure. So just being that resource to let them know what it looks like realistically in the home. And like I said, identify any potential barriers. They're also the ones, this is important because it helps with that length of stay. If it is something that we get early referral notification and they aren't going to be appropriate, then we can go ahead and let the case managers know and the hospital team know that we're going to have to go in a different direction. So just being that resource, even if it doesn't work out for us, we're who they call so we can help guide that process. And then also you have intake and reimbursement, and they play a big role because is the patient going to be covered once they're home? Are they going to have a high copay? Are they going to be able to afford that? Is it Medicare and that IV antibiotic is non-covered? Are they going to be able to afford those out-of-pocket costs? But your infectious disease physicians are wanting to know at the beginning of therapy, are they going to be able to complete it without any disruption? And so we're their resource to let them know what potential barriers or problems there could be, and do they need to adjust it? Okay, you know, plan A isn't going to work, let's look at plan B. And so we're their partner and the ones that are able to tell them what's going to be successful for an outcome in the home. It also allows us, with us having Epic and being able to go in, with ID only being the consulting physician at this point in the referral process, we're a safeguard for them because we are the experts. We work with them closely. We know what their expectations are, and so we can make sure everything is taken care of where they might not even realize that the patient is being discharged. I have one account that I work with, and they still have a hard copy order form. So it has all the final recs, home health orders, labs, all of that on there. Well, we know if we did not receive that hard copy order form, ID does not know that patient discharged. So if a hospitalist wrote us orders over the weekend and we started them, we know first thing Monday morning, we have to call that ID office to let them know the patient was discharged and to confirm that the hospitalist orders are actually what they wanted to go home on. So we're just able to really be in there and, like I said, be that safeguard for them.
That's the part of the pre-discharge. Then there's the side of the relationship build is on post-discharge, and that's really your home infusion nurse that you might have a relationship of monitoring the compliance and what's happening with the patient, more education that they may need based on the drug delivery device. But it really does come down to it is the clinical pharmacist role. Is that side of that relationship as a fellow colleague with the physician or nurse practitioner or PA that's in that office of communicating what's happening with that patient. And that's a vital role. Pharmacists in this aspect have to understand the things they do affect her passion. We want to get more referrals, right? And it's really important, being responsive, knowing what's going on with that. And one of the goals we always look for in developing these relationships is the communication. If changes need to be made on the dose, if there's an adverse drug reaction that is effective with the physician and their office practice and not cumbersome. And a lot of times what you really are looking for is you have to prove that. All of this is relationship building, and all of it is you gotta find the opportunity where they recognize this is who I want to work with. And it's a repetitive thing. It's a lot of times, even from a sales standpoint, going in, I'd like to do this and we want to be your primary. It's not going to happen. You really got to work on what your relationship side is. So as we all know what the pharmacists do in effectiveness. Because in the old days, a lot of the physicians still did the dosing adjustments and things like that in the hospital, but now they have a clinical pharmacist do it all. And we've had several physicians say, can you guys do this? Because I don't know if I can do that. And it's like, absolutely we can do that. Will you be accessible to us? Yes. And we'll talk a little bit more with that. So obviously we're talking IV antibiotics. This is our patient population. I'm not really going to go into it very much. Your patient population diagnoses do change. Cystic fibrosis was a large group for us, pediatrics and adults in the South, but that's really decreased with the change of therapy of CFTRs. That's taken that whole element apart. How did we build relationships there? They had a cystic fibrosis clinic. They didn't have a pharmacist there. It's like, well, compliance is a key thing for cystic fibrosis. Can we volunteer and join your team when you have a cystic fibrosis clinic? So we can emphasize compliance and other things that the patient could do. And that's worked well. Of course, that patient population is decreased. Now we have a unique population that's also come up, is NTM, which is non-tuberculosis mycobacterium. Very difficult drug, very difficult disease. It's long-standing, long-term therapies that you deal with. They've got to have somebody that can be with that patient, monitor adverse reactions and monitor that. So you have relationships there. You don't have high volume, but those are the unique things you want to have. They got to have somebody that's dependable with that. Go ahead. The other thing I'll be honest with you, a lot of times, and I don't want to offend anybody if I have a physician in here, they could really care less about the details of what's happening. They just wrote the order and said, just make sure it gets done, right? Sometimes they don't take into fact that if I ordered this drug, how easy it for that patient to give. And a lot of times this is where you are, whether it's the pharmacist or whether it's a liaison at the hospital, you're working through those things, how to make sure that that patient's going to be successful. And we'll talk about that. We got to go through what's the stability issues. I had one physician where he said, I really still don't want to use this drug, but you guys say it has poor stability. Well, it has poor stability. It's only got 12 hours or 8 hours at room temperature. We can work around it. Oh, you can? Yeah. Here's what we would do. This is what this patient needs. We'll do it. So you kind of look at those relationship sides. They are also very interested in cost. They're very interested in cost for their patient, right? They're not necessarily interested in your cost, but they do in some ways because actually they're a great target for advocacy support. And we'll talk a little bit more about that.
So how do we meet those shared outcomes with our infectious disease physicians for their patients? And one thing that we have, that we do is called a collaborative drug therapy management agreement. It's basically just a memorandum of understanding. Now these can be practice-wide or they can be physician-specific, just depending on what they're wanting. But all it is, very important to point out, it's non-exclusive, there's no money exchange. It's just a way to define, define their communication, their needs, their goals. If there are certain labs that they want with certain therapies, we can have that in place. How do they want that information communicated to them? Do they want it a fax memo? Do they want a secure email? Do they want to know right away if it's we're able to manage it and the patient's safe and everything's going well? Or do they want weekly reports? So it's just a way for us to be that true partner. We're the experts. Let us handle it. And we can provide that same level of care that the clinical pharmacist is providing on the inpatient side that they're so used to. Now we can carry that over and do it on the inpatient side. And we have these types of agreements with multiple different types of practices. So we have them with the hospital-owned infectious disease groups. We have them with an academic institution, and their patient population is a little bit more complex, and so they wanted it to be an opt-in option. So it's not automatically when we get a patient on our service that we go by our collaborative therapy agreement. They let us know when they want to use that. We have one with a rural hospital that they do not have an infectious disease group, so they are outsourcing to another healthcare system that is providing telehealth ID consults. So when those patients go home, it's going to be your residents, your hospitalists, or your internal medicine physicians managing them. So we have them with the internal medicine physicians and residents. And I'll say I had that physician at the rural hospital call me in a panic one day. She had a patient that had arrived for his follow-up appointment, and he had critical lab values. and she didn't know what to do. So I was able to determine that we were already aware, we had already talked to the patient, told them to hold today's dose, we had already instructed them on how to restart with a new dose the next day. We had communicated that to home health, we had actually communicated that to that physician as well. She just hadn't had a chance to review it because she had been in clinic all day. But the response I got was she was just relieved. She was like, oh, thank goodness, I'm not an ID physician, it's all taken care of, I can go on about my day. So it's just a great way to take it to the next level. I particularly love having these agreements in place because it's not a sales call. It turns the conversation more into the clinical side of things. I will say that once we do get an agreement in place, I do go sell it at the hospitals where those physicians consult and round. But it just adds credibility to us. The physicians believe in us. They see us as a partner. We are who they want treating and providing those services for their patients. And so it does allow me to have an open at those hospitals where we might not be getting as much business. Then you have unique opportunities that arise where you can show how you want to support the ID groups. So think back to when COVID first hit. Your ID physicians were completely overwhelmed. Everyone that was in the hospital wanted to go home. No one that needed to be admitted wanted to be admitted. So what we did is we established a COVID care fund, and it's basically just an allotted amount of money that we were able to use to support the patients that were either uninsured or underinsured. So it allowed us to help that patient population get the therapies that they need in their home without causing a financial hardship. So we were able to service over 20 accounts in our service area. We prevented 53 hospital admissions. We saved 1,714 hospital days. And what's most impressive, I think, is we saved close to $3.5 million in hospital days saved by doing this COVID care fund.
You know, one of the other things about the collaborative practice agreement that we do, it's hard to get signed. Physicians a lot of times are risk avoidance, like am I setting myself up for a legality, a liability issue? And part of it's what we're really doing is let's being on the same page, identifying what those roles are. And you present it, and you present it again, and then things get a little bit easier as that the relationship builds. They say, yeah, we really need to do this. Here's a good example of that. Even if you don't have an agreement, if I have a group, I like to do an annual review if I can get an access to them where they can come in and we can talk about it. And what I'm really looking for is that clinical aspect of relationship side of it. So we'll look over, of course, from a sales marketing side, we'll talk about satisfaction. They assume you have great patient satisfaction. They already know that. They already think that you have a great service in terms that it's going to be reliability. But the things you're looking at is, what is your antibiotic utilization trend? How does it compare to other physicians in the same practice area? You can blind it, you can de-identify it, so they can look at it. The groups I like is where there's 5 to 6 of them. They want to know what their partners are prescribing. And they'll find one drug and they'll say, who ordered that? And it's it's a unique case. This is what it was. Oh, I can understand why they ordered that drug. And they go through that. The other thing, we're actively involved with NHIA's, NHIF's benchmarking of status on discharge. What was your completion? And again, they're assuming that it's going to get there. But to show a number, I think is very, very important. It also creates an avenue for discussion. Here's what our adverse drug reactions were during this period of time. This is what we had to handle. And in fact, we had a large group, infectious disease group, where most of the management of the antibiotics were done by nurse practitioners. And again, not going to offend anybody when I say this, sometimes a pharmacist and a nurse practitioner can have a little turf battle in terms of what the therapy, how do you manage the therapy. So in this part, we're talking about vancomycin, we're talking about we'd like to have a little bit more response from you. They like to put this stuff at the end of the day. Well, that's our hard time. I want to know it when I have the results. As well as we brought up, I said, one of the things that I'm going to recommend is I think we need to give some of these patients more fluid. And it's really the education process with them about, when a patient's in the hospital, they're on IV fluids, they have more fluid going in, then they go home, they don't have the IV line in for the fluids, and they don't want to drink. Next thing you know, their renal function gets compromised, and immediately we started talking about what can you do to proactively, if you're starting to see the renal function getting compromised, give more fluids, can you add more fluids to the dose? And that immediately started to go through, and that helped us eliminate some of those things of change of drug, loss of the patient on therapy, or actually having it be discontinued. So those are the things you're looking at. Venous access, let's talk about the different catheters. Is a dual lumen or a single lumen more infectious? Which has a higher catheter infection rate? You can talk about those things. We had one group where their PICC lines were clotting off, and they kept saying, what are you guys mixing? What's causing them to actually cause being clotting? We need to increase your heparin from 10 units to 100 units. And we're like, okay, we'll try it. They were still clotting. Well, and the open discussion was, are your catheters clotting in the hospital? Yeah, they are. They really are. What type of PICC line catheter are you using? Oh, we had a great buyer in our procurement department, got a great deal on this new catheter, PICC line catheter, which in its side caused the blood to coagulate. And it just was like, can someone call and say this is causing too much of a problem? And that was changed. That catheter was changed. But it wasn't until we actually got involved that we really promoted that side of it. Obviously, you can look at drug delivery options. They just, again, assume things are done easily, or the physician thinks, I want it to be on this pump and this way because I got to be assured it's going to be controlled and administered. And I usually come back and say, wow, there's a lot of other options that make life a little bit easier for the patient. They don't need to have something strapped up all the time. They don't want to have that. They got a life. We're talking about getting them back into their normal daily aspect of that. So we'll look at options, whether it's elastomeric, or whether we call it a syringe infusion. You've got to make it real on that part of it. And then the other side of it, I love to talk about advocacy, is we need our Medicare population to get IV antibiotics. We got to do that. I need you to support. I need you to write a letter when this is coming up. And those are the things I think is important from that side. So another little case study, and probably most of you don't have this issue. Same day or last day, one day referrals, usually on the weekends, are coming out, and it's like, you guys have known this patient's going to need antibiotics. Why didn't you let us know? Well, it's easy to go to the physician and say, let us know earlier. But data tells you something. And so in a large teaching academic hospital, we started doing a retrospective review of a lot of our patient population of IV antibiotics. We looked at what medical service it was, what facility it is, multiple billings. You got different people involved on it, different residents. We found that close to 60% actually were typically same-day referrals. And, that's Fridays, that's right before the holidays, things like that have that. Now Saturday discharges real quick. And it's like, we need better notification. So we looked at it retrospectively. We looked at, most of these are a medicine, surgery, hospital, general hospitalist-oriented teams. ID had a consult earlier and said, this is a potential IV antibiotic, but we were never ever notified. Because the terminology, how do you notify somebody? They think, well, I got to notify home health. Or, I can't notify the home infusion company until I have final orders. And I'm like, no. I want to know then, because discharge planning occurs when the patient's admitted. And so when we looked at that and started presenting the numbers back to it, we found that 50 to 60% dropped to less than 5%. The average time the ID had a recommendation in the patient's record was anywhere from 4 to 6 days ahead of discharge date. And it's like, case manager's like, well, the physician does this. Well, that's when you got to get the medical team directors involved. And we're actually still in that process of working through that. You're still going to have some same-day discharges, obviously. But I just want to be more involved in that discharge planning side, because that patient may not go on IV antibiotics. They may not be a good candidate, but I can also stimulate the thought that maybe there's another better side of care, or can they be discharged sooner? Because I've actively become a little bit more involved. There may be a reimbursement issue, there may be a caregiver issue. those dynamics. And you know, we're all magicians when it comes to that patient's being discharged, and we're like, oh, wait a minute, we're not ready yet. But you got to make it happen because they're already down the road. And it's like, where can we prevent those pain points coming into play? So that's what we do. We collaborate. We try to make sure that they have that communication. But data is important. I can't tell you enough. Look at some of the data that you have or you can collect and go back into it. You'll actually get a better response. So here's another one. Here's another opportunity. I talked about the NTM patient population. And what we looked at there was we have patients, these are patients who are on weeks. They can be anywhere from 8 to 12 weeks. Sometimes their therapy are more complicated. A lot of them are oral, some are IV. This young lady, 62, I think she's young, has a diagnosis NTM, adult pulmonary group. Well, go ahead. She's going to be on Nizira, 100 milligram once a day. It's great, easy to do. We can do that in the home. Oops, she has Medicare with a supplement, not covered. She immediately said, I can't afford this. Thinking about that population, that infection, it's lifelong. She's going to have episodes of this forever. And the question is then, what do you do in that part of it? Well, in that aspect of it, can we potentially do that? Where does she live? Does she have a viable option to be able to go to an infusion center every day? Well, in that part of it, talking to the physicians in that group, one of the things that we did, one of the things we looked at and said, okay, this is going to be really cost prohibitive. What can we potentially do? We shifted it to our ambulatory infusion center, the provider-based infusion center, and the physician between the back and forth and said, why don't we just do it through Monday through Friday? We'll give her a weekend off, and let's see if therapeutically if it will work. And we've done that now for 3 8-week courses for this lady. And she comes in, she knows what she has to do. She's very appreciative because the fact that it's covered, but it could have easily been done at home. Could she have done this at home? Absolutely. She's one of my strong advocates now in campaigning for Medicare coverage. Those are the opportunities you look at. But the physician group is what you're looking for. Be viewed as that relationship side of being a problem solver for them and what's really happening in that communication side. Okay, last slide, yours.
Okay, so as we come to a close and we finish up, I want to answer the one question that I know all sales reps are asking in their head right now. How do I gain access? How do I gain access to the case managers when I can't walk the floors? How do I gain access to my infectious disease physicians when they are not scheduling in services and they will not see me? So it's all about being persistent. You have to be persistent and work every single angle. So a couple of things that have happened in our market where we have created opportunity is change in ownership. Are there new healthcare systems coming in? We have an ID group that we have worked with for years and have a very strong relationship with. Well, another healthcare system acquired a smaller healthcare system in that market, and now that physician is going to go develop the infectious disease program at the new hospital system that just entered our market. So we know right away we have a great support person, we have a great ally there, and so when she gets on her feet and up and going, we have an in. Then hospital-to-home programs. There's a hospital system that we are not the contracted provider at, and unfortunately, their contracted infusion pharmacy was not able to meet their needs. So they reached out to us, and we have been able to partner with them and provide those hospital-at-home infusion therapies. So it's a small little carve-out, but it's gotten us in. So of course, from the sales side, I'm going to be looking to see what other avenues can we work and how can we grow that. Market changes. We have, I had one sales rep that called on a hospital system for over 1 year, and they had their own home infusion division. She never got one single referral, but she was persistent. And while she was calling on that hospital system, she was also working the infectious disease practice as well. And she was successful at getting some referrals from their clinic. So we were able to prove what we were, the level of service that we were able to provide and start establishing that relationship. Well, then the hospital decided that they were going to close their home infusion pharmacy. So that opened up an opportunity for us. And because we had already been in working with the infectious disease group, they were our advocate, and now we're the contracted provider. So her persistence paid off. We went from having no inpatient referrals to now being their contracted provider. Is there a payer that your competitors are out of network with? Is there a little angle that you can work where you can start getting in and meet that gap and meet that need? So those are just some of the ways that you can create that opportunity in the areas. So that's all we have today on collaborating with infectious disease. And so we'll open it up for any questions. And I'll put this mic back up.
That's okay. I have a question about the AIC setup. Obviously, you're an infusion pharmacy. So if you're not able to bill Part B for some of the Medicare drug, you're billing them under the AIC. So what kind of licensing do you need for that?
It's in our state, you got to set it almost like a physician-based infusion center, and you separate that. You look at your state's corporate practice of medicine. From a licensing standpoint, it's pretty much, there's not really, from a pharmacy standpoint, you don't need that. You may need it if you have drugs in that area, but we support that from our home infusion side, so it's really within that same umbrella.
So, so under what NPI number do you bill?
We have said it's a different division of ours. We have a separate NPI number. It's not all under the home infusion. If I did it in infusion, that would be the suite side. Well, I would use my pharmacy contract. It's a total different work of agreements with the payers and then getting your different NPI number.
So how do you get it under a pharmacy entity or?
No, it's really more as a medical side. Yeah.
And you have to have a physician or a nurse?
Yes, I have a medical director, and we really have then nurse practitioners.
Okay, thank you.
Any other questions?
I've heard a lot of different things from different people about the hospital-to-home programs. I'm curious what your experience has been.
Limited. And I think a lot of that problem is just some of the regulations, but it's also the hospital-to-home is more institution-based, and I just don't have a lot of confidence in sometimes the hospitals understanding really what that means. They're looking at how can I capture some more of this revenue and reduce length of stay, but they forget some of the key components of that ties into that. And sometimes for us as a provider coming into it, we want to be part of it, obviously, but they always are looking at, well, we want to use something internal. But they really need us as a home infusion provider from an expert side. But it's been limited. Some of the bundling programs prior to really the hospital home was something that we actually got involved in a couple of large hospitals, but it's been limited. And then I think a lot of that limitation is more due to the institution not knowing what to do. They're indecisive, and because of that, they waste too much time and they actually really lose money from that side. Anything else? Well, I just have to compliment Ansley. It's passion. You can see her passion when it comes to really not just from a sales marketing standpoint, but she's real passionate. So if you're in the sales marketing side, you've got to have that passion not just for the sale, but you got to have it for your clinical team, and you got to have it for that patient. And you got to be standing up for that. And you have to be open and transparent. There's several times that we get into it. You've just got to be upfront. This isn't going to work. And it's very important with that part of it that you develop that trust. And that's a strong thing. And that's what we really have as a full team. Everybody has to have that. And I like to see her passion when she has to go to our pharmacists and say, did you realize you were not responsive enough for this physician? And they're like, yeah, but you don't realize. No, every one of these things are important. Or it's the nurse, or it's the nurse communication. Tallying off of that and promoting each other as what your team is. That really does help.
Sparked another question. What sales tools are the infusion centers, what are you developing together so that you have the tools to report back to existing referring physician offices or hospitals, and then what has been successful in helping your sales force communicate the progress and the quality that you provide?
Thank you. So we are a small company. I have 2 sales reps that help me cover the entire state. And because we have long-standing relationships, a lot of it's just been conversation. And then when we're involved in that referral process and they're hitting those barriers and need those infusion center services, we just offer them up and say, we can provide those services. We can take that on. So it's really just been relationship focused. And then we also have some software. So when the patients come in, we have a post-therapeutic letter that is developed and automatically sent to the referring physician. So it notifies them that the patient was seen, what labs were drawn, their dressing was changed, and when their next appointment is.
Also include how sales can get involved. We still do the morning rounding, where everybody kind of connects, and we really want sales to be involved in that as well. We have a virtual board that we call, it's really communication where patients are progressing. And in that part of the morning report or huddle or that part of it, what their need to be listening for is this patient had trouble, this one there, and their part is, do I need to respond to that? Or a clinician say, we haven't heard back from a physician, so I'll run by there, that office. It's that connectability we have, and that's really a very important side of that. They're looking for, what do I have to address that we may have missed? I mean, we were complimented, I always think we're complimented when a physician says, can I call your pharmacist directly? Here's my cell phone number. Text me when you have an issue. We had one great ID physician, and his initial response is, of course, they're trying to, time is their commodity, they want to control, is if you want to get a hold of me, call my office. And it really got into it and said, well, it's kind of hard because it might be a 2 to 3 day delay. And he goes, why? Because the communication doesn't work. And immediately he said, well, here's my cell phone number. That was the access. The other part is the relationship also might necessarily be with your entire department, but it might be one of your clinicians. It might be one pharmacist. Why? Something happened, developed a communication very quickly by phone. They want to talk to that pharmacist. Why? Because it's common. You got a trust level. They know what's happening with that part, and you got to cherish that. You got to also really help that person maintain what that relationship is. It's also important for them to say, I'm part of a team. If I'm not here, these are the other people you can access to. Okay? Thank you. Thank you very much.